Ramon from Ramon y Cajal Hospital, and this is the third webinar of 5 about coronary physiology and imaging. And today, and firstly, I like to thank Abbott for sponsoring these webinars. And today is a honor and a pleasure to have with us Dr. Nicolas Amabile from Paris, from the Institut Mutualist of Montsouris in Paris. And Nicolas is one of the biggest experts in imaging, coronary imaging, and coronary physiology. He published recently the Lemon study, which OCT was proven, which is a study about the feasibility and the usefulness of OCT in left main coronary artery stenting in the left main. And also he has a lot of publications in this topic. And the title of the presentation is the OCT, is the useful and how to improve the results of the complex PCI with OCT. And this is the title of the presentation, and also is the aim, the objective of this webinar. And secondly, we have a live case from Ramon y Cajal, and in this case was a very severe calcified lesion in the RCA. And then we started to do the case. It was a very complex case, and for us it's better to start with the case and to finish the case, and then after that Dr. Amabile will give the presentation. For the case, I will present our team. The first operator is José Luis Mestre from Ramon y Cajal Hospital. And now it's a pleasure to have with us also Dr. Santiago Jiménez Valero from La Paz Hospital. Is one of the biggest experts in OCT in Spain and in the world, and is a friend of mine, a friend of ours, of us, and it's a pleasure to have Dr. Santiago Jiménez Valero. Then we will present the case. Dr. Ana Pardo will present the case.
Okay, thank you, Angel. Good afternoon. I present an 82-year-old female with past medical history of hypertension and dyslipidemia, and with a symptomatic severe aortic stenosis due to angina. We performed a coronary angiography as part of the study previous to the transcatheter aortic valve implantation. And this is the result. Here you can see the left coronary artery with no significant lesions. And in the right coronary artery, as you can see, there's a very calcified lesion in the mid segment. And so we are here today to treat this lesion.
Okay, thank you, Ana. Then I don't know if we can see the images of the case. Show the image, José Luis. I will show you the first angio. This is a right catheter, the 3R3D catheter for right coronary artery. And then you can see a very severe and very calcified stenosis in the mid RCA. And in the first option was to perform OCT to see the artery and to see the morphology, the length of the lesion, the diameter. But the first step, the catheter of the OCT didn't cross the lesion. And then the first step is to perform when the catheter doesn't cross the lesion, the first step is to do in this case atherectomy, rotational atherectomy. And then this is the burn is 1.5 burn. We had some difficulties to cross the lesion with the burn. And finally, the burn crossed the lesion, but at that moment, the patient suffered from hypotension, bradycardia, and as you can see, a no reflow phenomenon. Then, Nicolas, are you there?
Yes, of course. Yes, I am here. That's
You can see the images, and then the first step. Do you do the same strategy?
Yeah, I mean, probably that it was a massively calcified lesion of the mid RCA. We know that OCT has a lot of advantages, but the Dragonfly imaging catheter has not very good profile in calcified lesion. It's going to change with the new generation, but so I think it's very, very challenging to try to cross this lesion with the OCT catheter. So maybe I would have given a chance to like small balloon predilation in case I was really in. I found that OCT imaging will be mandatory for this case, at least for preparation. But on the other hand, you have a very fragile patient, tight aortic stenosis. We know that these patients. We have to get the procedure as short as possible. So for myself, I'm not really. I would probably have done the same as you, rotablator up front, and then try to reanalyze the thing with the OCT.
Okay. Then after atherectomy, we try to do again OCT. Was impossible to cross, and then we predilate with a non-compliant balloon 3.15. You can see the dilatations, and it seems good expansion of the balloon. And then we perform OCT. And Santiago Jimenez Valero, Dr. Santiago Jimenez Valero will show you the OCT and explain the findings of the OCT.
Layers of the normal artery. There is no plaque at this point. More proximally, we have some artifacts, the CUAP effect due to some entrapment of the OCT catheter. You can see these artifacts due to entrapment of the catheter. And as we go proximal, we can see several disruptions of the calcified plaque. You can see here, for example, this is the calcified plaque with deep dissections. And in some points, there is a critical stenosis, but as you can see here, there is a very, very profound, very deep dissection in the opposite side of the most calcified lesion. At the points with severe stenosis and very severe, you can see more dissections due to the rotablation and after dilatation with balloon. You can see a nice picture of a fracture of the calcified plaque. You can see calcium here, and a very deep fracture of the calcified plaque. And more proximally, you can see the very deep, the thickness of the plaque is very high. We have measured nearly 1 millimeter at this point. You can see here. And finally, in the proximal part, near the proximal part of the right coronary, have some eccentric plaque, calcified plaque, very with a nice amount of calcium, but there is, at this point, there is no significant stenosis and no dissection. So we think that it's not necessary to treat until the proximal part to the catheter.
What do you think, Nicolas? I think we can see the fractures in maybe in the all segments. We don't see a circumferential calcified lesion, and maybe now is.
I agree with the interpretation of these beautiful images, and that's very interesting because you see that with rotablation, you can do more plaque modification than just atherectomy, and sometimes you observe this kind of fracture within the calcium, meaning that the technique was efficient, and so you're not, maybe you won't see like massive debulking of the lesion, and rather this kind of longitudinal fractures within the plaque, and meaning that I think that the technique was successful in this case.
Okay, and the next step, Nicolas, do you implant an stent, or you perform more dilatation with another balloon, cutting balloon, or do you think is enough to do?
I like try to maybe put another non-compliant balloon inflation step before implanting the stent, to be sure that there won't be any imprint on the balloon, and but that's personal. In addition, I don't personally use the cutting balloon on the top of rotablation, but I know that this technique, this approach has been also proposed and appears to be successful in some publications. So once again, I'm pretty open to any option, but I would personally go for a post dilation or a dilation with a non-compliant balloon.
Okay. Then we are, because the fair balloon is a compliant balloon. Yeah.
I believe you can. We can show again the balloon inflation with the 3.0 non-compliant balloon in the mid part of the RCA, because as Nicolas said, there is some imprint in the balloon. It's not complete expansion. I can see the OCT images now. I will move to the angio. You see the next. I don't know if this inflation you can see over there.
Yeah.
It's not completely expanded. I don't know which pressure you used, Jose Luis, here.
Maybe 16 atmospheres.
16 atmospheres.
Yeah, but it's a compliant balloon. It's a compliant balloon. It's a non-compliant balloon. Semi-compliant balloon.
My question for you would be appropriate to just put the stent, and if the stent is not completely expanded, use another technique such as lithotripsy after implanting the stent?
Yeah, I think now maybe it's better to dilate the lesion with a non-compliant balloon and to check the stenosis.
Second question would be, what is the perfect timing for this kind of PCI in patients with aortic stenosis? Would anyone, and you can write it in the chat, prefer not to touch the coronary artery, or maybe do it at the time of TAVI, or maybe after? Does anyone has any comment regarding this timing?
Nicolas, what do you think about this question? Before TAVR, at the same time, before, after?
No,
in this case, it's a mid-RCA, a critical stenosis. Is not a left main disease, but it's a critical stenosis in the RCA. What do you think?
I mean, in our institution, we would go for sure for pre-TAVR PCI. One of the question is, should we perform a valvuloplasty before this high-risk PCI or not? And I think that it will depend. As for ourselves, when we do rota and when there is a risk of no reflow, most of the time we go for valvuloplasty, then PCI, and then TAVR.
Okay, our study is the same. In this case, we don't expect to have a no reflow phenomenon, but it was a transient no reflow phenomenon. Now the patient is good, and we solve the situation. And in this case, the patient, we will implant the TAVR tomorrow. It's nearly at the same time. If there are more questions in the chat, no more questions, and then The second step is to try to dilate the lesion with a non-compliant balloon, 3.15 millimeters. 3.5 millimeters. And the length 15. So Nicolas,
What would be the length of the lesion by OCT if you had to put a stent? Have you measured it?
37.
37 millimeters.
Oh,
37. It's a very long lesion.
So that's the reason you kept
Now,
this
we have
extension of
also
the guiding catheter there.
Yeah. Yeah.
We have also need predilatation, so we need to cover all the treated segment with a stent. We have
Nicolas,
measured 37.
And in the meantime, in the meanwhile, do you have experience with several devices, orbital or rotational atherectomy? What do you think about these devices? When do you use one or the other, or what do you think?
So in my center, we have rotational atherectomy and intravascular lithotripsy. Orbital atherectomy has just started in France. And so we've got pretty good experience with both devices. I think it's right now our usual indication for rotablation are when the lesion is uncrossable with a balloon, or when there is a residual imprint during predilation, and so we will go for this plaque modification strategy. As for the shockwave, we use it when there is a residual imprint on a non-compliant balloon. And I think that, but the time will tell, but probably that both techniques are more or less complementary rather than concurrential and competitive. And so we try, and I think that in the future, we think, and I will show you that in the presentation, the OCT imaging will help us to decide which device is the best for and is the more adapt for any kind of calcified lesion, depending on the extension and the severity of the.
Okay.
O si quieres un 3,40 y pues dilatar luego con el balón de 3,5 la parte proximal. La parte distal era 3.
Santi, show us please the dilatation with this balloon. Please. I think after 3.5 balloon, there is no residual stenosis and the expansion of the balloon is good. And then I think we can implant an stent.
So which size did you decide to, will you go for a 3.5 per 38? Longer?
Sorry, 40, no, probably 40, 30, 3.5, 40.
Okay.
Si tenéis algún de 3,5 40.
¿Traes un Science 3,5 por 40 o...?
And then continuing to talk about the calcified lesions, and you said you talk about the lithotripsy. When do you use lithotripsy or rotational ablation? Is rotational ablation only for when you don't cross the lesion, but if you cross the lesion, you can dilate, and then the second step is to dilate with lithotripsy? What's your strategy in these cases?
Well, I think
medio 37 de sano a sano, o sea que sí que siempre cojo un milímetro más para no andar muy apurado, pero 38 yo creo que sí que
in the case you are presenting, I think I would have definitely did the same. I would have definitely do the same strategy, and first start with an upfront rota, and then try to inflate non-compliant balloon, And in case there is no imprint, I think it's good to get the stent. I think that lithotripsy in this case could be considered if there would, in case of any residual imprint on the final non-compliant balloon inflation, because if you observe this kind of imprint, you really can anticipate that your stent will be not very well expanded, and then it's going to be much harder to recover and just to change the situation. So we can combine rota and shockwave, but it's quite rare. Most of the time, rota plus non-compliant balloon can do the job.
Okay.
As you are doing right now, it's beautiful.
And talking about imaging, when do you use IVUS or when do you use OCT?
That's a good question. That's a very good question. I think that to be clear, I think that 90% of the lesion can be explored by both OCT and IVUS. The only, of course, you're gonna have a better, the quality of the image was gonna be better with OCT compared to IVUS, and with much more details. On the other hand, you're gonna use much more contrast. Well, not much more, but you're gonna use more contrast with OCT. So I think that the only lesions that you cannot explore with OCT are ostial lesion, very, very large vessels, and probably severe renal failure patients.
Okay, and talking about the Lemon study, what do you prefer, OCT or?
I will show you in the presentation. I think we are using both. There are much more evidence right now with IVUS, and IVUS is in the guidance of left main PCI is in the guidelines with European guidelines, and we know it's really there is when you predilate or when you treat a left main lesion with the guidance of IVUS, you can really improve the mortality over time, and that has been especially proved by the Spanish group by Chemla de la Torre Hernandez. On the other hand, we just need more evidence with OCT, but OCT appears to be very promising. Just to wrap up, I think that you can use both techniques, and but I would probably not go for OCT in case there is an ostial involvement of the in the left main. So for ostial left main or a long lesion of the left main involving the ostium, I think that IVUS is maybe a better option compared to OCT right now. Maybe that in the future is going to change. But if you have a mid or distal left main, OCT is really, really efficient.
I agree with you. I agree completely with you. Now we go back to the live case. This case, Jose Luis had the difficulties to cross the lesion with a stent. He had to use a guide liner, but in the end, the stent crossed the lesion, and we will show you the angio after the stent. It's a very long stent, very big and long stent. It's difficult to cross the lesion with this kind of stents.
De hecho, a lo mejor lo Vamos a hacer otra OCT.
Okay.
Para ver el stent y la parte proximal.
Hacemos una angio. Then we will show you the first an angio after the stent, and then we will repeat the OCT study to check the expansion, because at the beginning it's very important to assess the lesion with OCT. It's very important the rule MLD, the morphology of the lesion, the length of the lesion, the diameter of the lesion. In this case, it was impossible to study the lesion because the calcium didn't allow us to study the basal artery. But after the atherectomy, rotational atherectomy, and after the balloon, we can check. We can see the coronary artery. We saw the fractures, and then we dilate with a non-compliant balloon. And then now it's very important to see and to check the final result with OCT. It's very important, the MAX, the max rule, the medial dissection at the edge of the stent, the expansion of the stent and the position. And then we will check these aspects in this case with OCT. I don't know, Marcelo, are there more questions from the chat?
Por ahí, vale. Bueno, retiramos el guideliner para ver la parte proximal. Y hacemos otra vez 12 a 3, eso es. Vale,
The catheter is in the distal part.
Is this the new OCT catheter? Okay.
Yeah, this is the new OCT catheter. Yes, it's true.
Vale, ya lo tienes.
Okay. It's important to clean the artery with contrast in the distal segment of the catheter, and then we will start with the pullback. Nicolas, can you see the screen?
Yes, yes, I can see that.
There's a lot of movement.
Yeah, that can happen in very calcified lesion, but
Yeah.
Of the stent is good, is good approach, and there is no distal dissection.
This is a branch.
It's a mild malposition. There is a
This is a calcium nodule.
there's an, yeah, near the proximal border.
As we expected, there are some areas of malposition, mainly in the proximal part of the stent. And this is the typical image when there is a nodule, and it's very difficult. And then in this case we see a nodule, but after rotational ablation is not after balloon. What do you think? Nicolas,
yeah, it's quite well. I mean, sometimes just adding the stent, you know, there is an option to show all the stent struts or the stent struts identified by the software, and in some cases it could be confusing. I think for the expansion it will be tough just to use the automated software expansion calculation. To me, there was no distal dissection. I could not see any prox dissection or major dissection. And then you have some areas of malposition. It will be interesting to measure if these malposition are less or more than 400 micrometers, which is the threshold proposed by the EAPCI to correct the malposition. Otherwise, if the malposition is below 400 micrometers, I think it won't be it's not worth trying to correct that. And of course, we're a little annoyed by all these artifacts, but you can tell you can have some information on this run, and probably that maybe that doing like a further step of post dilation with non-compliant balloon could improve the result.
Okay. Well,
Donde no hay stent, a ver si hay disección residual.
no,
por
no,
ahí,
no. There are.
Ahí hay una pequeña disección.
Yes, yeah.
Es poco.
Yeah, there's a
But
prox,
it's
but
less-
it's a minor one.
Yeah, this is minor. I think it's less than 1 millimeter. It's
como
not
mucho eso.
circumferential. Yeah, I think it's better to post dilate with a 3.5 balloon,
Yes.
a non-compliant.
Yeah.
Okay. Then we will do a post dilatation, and I think it's time. I think if you want, Nicolas, I think you can present. You can give your presentation, and then at the end we can show the final result of the case.
I
Do you
think that's, yeah, that's a very good idea. So I will start. I apologize for that. So the first question that comes in mind about OCT for OCT guidance for PCI is why shall we use OCT to guide our PCI? Well, actually the answer is pretty simple. We want to perform the best PCI as possible to provide, and OCT is useful to provide a more appropriate and tailored PCI strategy and prevent the inadequate results that will trigger short and long-term complications. Because we know that the suboptimal PCI results have two kinds of implications. On the short term, it could lead to acute, subacute stent thrombosis, and later to late stent or very late stent thrombosis. The other complication of PCI will be restenosis that could be related to a neo-intimal hyperplasia or to neoatheroma. In both cases, both thrombosis and restenosis will lead to adverse clinical events, and that will impact the patient's outcome. So just to show you a very what we would like to avoid in our patient, that's a 57-year-old man with an acute lateral STMI. He had a previous drug-eluting stent implantation on the prox circumflex and first optimal marginal branch. He got 5 years before. He got previous EES implantation for restenosis on the same site 40 months before, and he got this stent thrombosis. We deoccluded with a POBA and provide this patient some DAPT and low molecular weight heparin. We deferred our angio and OCT control for 3 days. You see that's the result after the optimal medical therapy. And the OCT actually revealed that in this patient, there was the first stent implanted 5 years ago, the second stent implanted 40 months before, and actually the second stent was grossly malapposed, which led to this stent thrombosis and this STMI. So that's what we would like to avoid, and so that's why we want to get the best PCI as possible, and OCT will help us. So, but I know that it's very challenging because of the volume and of the cost. We could not probably right now provide OCT guidance for any patient. So we have to consider it when, in several cases, when the lesion is ambiguous or when the appropriate PCI strategy could not be identified by angio alone, or when inadequate post-PCI results could be anticipated. I think that was the case nicely shown by in this live case. Or of course, you need to you can use OCT, or you have to use OCT when the lesion is located in a crucial vital site and you don't want the patient experiencing stent thrombosis because it will be lethal. So the best candidates, in my opinion, for OCT guidance, OCT guided PCIs are the long lesions, the calcified lesions, the lesions with diameter discrepancies, the complex bifurcation in which you can plan a two-stent strategy, left main, the stent thrombosis as I shown, and the severe recurrent intrastent restenosis. I will be a little provocative about the concept of PCI optimization, because most of the people think that this PCI optimization is only when the stent has been implanted and you want to correct any abnormalities that you observed with the guidance. But in my opinion, the PCI optimization is a continuum that starts before any stent implantation. PCI optimization is getting the optimal PCI. So before stent implantation, you have to anticipate the forthcoming difficulties, which means that you need to provide an adequate strategy for the plaque preparation. You have to identify the adequate landing zones in order to get the best and the most appropriate device sizing. After the stent is implanted, you will check for the results and improve the results if you're not satisfied with them, which means identify the you need to identify the early pitfalls and correcting some of them, not all of them, but some of the high-risk abnormalities. So when you do OCT guidance for your PCI, it will always follow the same path, starting with a pre-PCI run in which you're gonna characterize the plaque and do the metrics, which are, as shown with the live case, the stent length, the diameter of the artery. Your PCI strategy will be established according to the plaque characteristics morphology, which means shall we go for pridilation, rota, intravascular lithotripsy, orbital atherectomy. You will choose your stent diameter and length. And in case you're dealing with a bifurcation, you will also choose your pot balloon diameter. The post-PCI run is set for the identification of the inadequate results and the early complication, which are mainly the stretch malapposition, the stent under expansion, thrombus, dissection, or plaque prolapse. If you're pleased with the result of your post-PCI run, that's okay, the procedure is over. Otherwise, you have to correct and redo your OCT run. So for the pre-PCI run, we're going to start with the pre-PCI run, and it's very important to correctly evaluate the calcified lesion in order to quantify this calcium, the amount of calcium, and that's something that can be done with OCT and not with IVUS, because IVUS is not very with IVUS, you got a full reflection of the ultrasound on the calcified lesion, and you're not able to correctly measure the thickness of the calcium and some of the extension. And you see that with OCT, you can observe different patterns of calcification. Here you have a very mild spotty calcification with a calcium arc extension below 90 degrees. That's a moderate lesion where the calcium arc extends to 180 degrees, and that's a severe arc calcified ring that you can observe here. It was the same with the live case, and in this case, the calcium arc extension is circumferential, and you can anticipate when you observe that, you know that it's going to be tough to get a correct result with your stent without preparing adequately the lesion. So how can we, is it possible to better measure this calcification? This score is the calcium score proposed by the New York team and was published 3 years ago. And it's a very simple rule. You measure the calcium thickness, you measure the calcium arch extension, and you measure the length, the total length of the calcium, and you grade your lesion based on these three characteristics, and you get a final score which ranges from 0 to 4. And the Fugino and colleagues observed that actually the higher is this score and the lower is the expansion, and the higher the risk of under expansion, which suggests that the higher the risk, the higher the score, and the higher the risk for subsequent stent failure. So can we prepare the lesion when, so it's good to measure and to quantify the calcium, but how to prepare the lesion? There are several algorithms that have been proposed based on intracoronary imaging to adapt your plaque preparation strategy to the features of the plaque. And that's the one we are using in a forthcoming randomized trial that we're studying in France named Calypso. We will propose different strategies based essentially on the calcium arc extension. You see that with extension below 180 degrees, we're going to start with non-compliant balloon as we discussed earlier. But when the extension is over 180, we can go for intravascular lithotripsy. And when you have almost a completely circular calcification, I think a rotablator is the first option. And you see that there are some crossover options, but basically that's it. During 2021, the past year, we have seen the apparition or just the launching of a new software by Abbott named Ultron that has, so it's based on artificial intelligence calculation, and it's designed to help the physician to do a better job with the PCI and to automate some steps in the OCT analysis, including the calcium detection. And here that's an example of a lesion that we treated. It was a severely calcified lesion that we treated with Ultron guidance. And you see that the software can really identify with this orange spot all the severely calcified part of the artery and perform a co-registration between OCT and angio and show you nicely. It can show you nicely where is the calcium burden and help you to do a better job. Second point that I would like to discuss with you is the appropriate landing zone identification. We know that when we try to do a OCT, when we do a OCT guided PCI, our aim is to put the stent from a normal to a normal section of the artery, which means no plaque. And unfortunately, sometimes it's not possible because the artery is completely there is really a diffuse disease, and there is no real correct or normal landing zone. So in this case, you have to deal with the reality and try to put your stent edges in fibrous plaque. Calcified plaque is a worse option, but the lipid plaque is definitely what you have to avoid. It's not very good to implant your stent edges within a lipid plaque, because then it will increase the risk of dissection, of peri-PCI myocardial infarction, and on the long term on restenosis. So if we classify the suitable to or unsuitable landing zone, I would recommend you to go for normal or fibrous plaque landing zones. So these slides, and I will go very quickly on that. It shows you the result of it was a Japanese study that showed that when you implant your stent within a lipid plaque, there is a much higher risk of stent restenosis during the first year of follow-up. Third point will be how to properly size, and that's not so trivial because as you see that there's something that we wish, and then there's something that we face in the Cathlab, and the reality is not always doesn't really fit our expectations. So as I mentioned, to properly size, you have to define the prox and the distal landing zones. Ideally, these landing zones will be the adjacent reference segment without atherosclerosis. But in case it's not possible, you have to pick up some landing zones with very limited atherosclerosis and a plaque burden below 50%. The definition of the Stein diameter is defined according to the distal landing zones diameter, always a distal landing zones diameter. And you have to define the stent length, which will be the distance between the prox and the distal landing zone. However, if we want to proper size, we have two options that have been proposed in the literature. The classical approach is the luminal diameter approach. You measure the mean luminal diameter on the distal landing zone, and you will round up the minimal luminal diameter to the nearest device size. So in this case, the average luminal diameter of this patient at this site was 2.9. So the device will be 3.0 because you round up. But the other option could be, and that's, of course, that's the same picture. You can go for the EL to EL approach if the EL is visible. So in this case, that was okay. There was almost no atherosclerosis. There's just a mild subintimal thickening here. And you will measure the EL to EL diameter and the average EL to EL diameter on the landing zone. And you will round down the mean distal EL reference diameter to the nearest device size. So in this case, the average EL to EL diameter was 3.2. So you have to round up you have to run down to 3. So it means that in this kind of case, you got the same sizing with both methods, but it's not always the same. And this paper has been published this summer showing that actually when you measure the stent diameter calculated by the EL to EL diameter compared to the luminal approach, then you observe a tendency to, there was a trend towards maybe a, how can I say, like oversizing with the EL to EL diameter. Let's move to the second OCT run, which is the OCT run will be for correction, for identification of PCI pitfalls and guidance of correction. So as we mentioned earlier with the team, we should not go for correction of any malposition or any dissection. And for this task, you have to refer to the proposed criteria, the criteria proposed by the PCI. For the dissection, you only have to correct dissection with a radial extension over 60 degrees, going over the intima and with a length superior to 2 millimeters. The malposition has to be corrected in case the axial distance, the distance between the struts and the vessel wall is more than 0.4 millimeters and more than 1 millimeter in length. And for the expansion, I think the expansion is the trickiest aspect because you can calculate in non-bifurcated lesion. You can use the doctor's criteria, which is the minimal stent area that you have to measure, or the software can measure it for you. The minimal stent area should be divided by the average reference lumen should be over 80%. But for example, it doesn't work on bifurcation because there is discrepancies between the diameters. Another criteria that can be used is that the minimal stent area should be at least over 4.5 square millimeters in OCT. But of course, you have also to adapt this result to the lumen, to the vessel. For example, a 4.6 square millimeters minimal stent area in the left main is not really appropriate, whereas it's very good in the distal RCA. So how to wrap up all this information, and I think that this MLD Max strategy, or the MLD Max acronym which has been mentioned by the team earlier, is a very good way to remind everything. The MLD means that refers to the pre-PCI OCT, and it's to strategize. So M is for morphology, L is for the length of the lesion, and D for the diameters. The second acronym is the MAX. It will refer to the post-PCI OCT results, and in order to help you to optimize by only focusing on the important points that are medial dissection, apposition, and expansion. And I will show you some examples further. When you apply this MLD Max approach, you can change your PCI strategy in more than 80% of the cases. And what is interesting in this work is that actually most of the changes came before the stent implantation. You see that if there is a cumulative OCT impact through the progression of on the workflow, you see that the majority of this impact comes before the stent implantation. So let me show you an example from the Cathlab, from our Cathlab. Was a very long LAD lesion in a young lady that we wanted to treat by PCI. And in this case, we anticipated that it will be difficult because it looks a pretty small artery, but the lesion is quite long and diffuse. So you can imagine that it's very difficult to get excellent result all along this long lesion. So we first, of course, used our guiding catheter, and we did OCT analysis that will confirm that we have some mixed apheroma, mostly fibrolipidic, and a long lesion, bifurcated lesion. And actually, this pre-PCI run help us to identify the potential landing zones. This one is a nice distal landing zone because you see that it's almost disease-free. This one is the proximal landing zone. It's still okay. Once again, it's not completely normal, but you can see the EL all around the lesion, and the fibrous plaque is very, very mild. That is the I would say the nadir of the minimal lumen area, and you see that there's some lipid pool everywhere and some fibrous. Not a lot of calcium, which is good. So that's a bifurcated lesion, as I mentioned, but we're gonna use the distal landing zone diameter. I prefer going for the EL to EL approach. This is the prox EL to EL diameter that will help us to identify the correct pot balloon. And the MLA is 1.7 square millimeters, so it's very tight. There is no calcification. The length is 4.5, and you see the diameters. So in this case, we can decide our strategy based on the MLD acronym, which is no plaque modification, no aggressive atherectomy or lithotripsy or cutting balloon or whatever. We will go for pridilation with a compliant balloon. There is no, at this point, we didn't add, it was 1 year ago, so there was no 48 millimeters Xience in our Cathlab. So we decided to go for 2 stents with a pot, a side dilation, and a repot. So the pot balloon diameter will be 4.0. In this case, I decided to go for maybe a slightly larger stent than the downsizing rule, but I think at 2.75 stent could have been also appropriate. So we dilated and implanted both stents, the 3.0 per 28 and the 3.0 per 18. we plotted the LAD with 4.0 according to the result of the OCT. There was still some imprint there, so we post-dilated with a 3.0 non-compliant balloon. We sided and reported, and that was the final results, which was so-so, but we did a OCT, and the OCT run, I will go a little faster. The OCT showed that the site of the bifurcation, the site of the side dilation takeoff was okay. The apposition was okay, but the expansions here was not okay because the MSA was 2.7, so we are below the 4.5 square millimeter criteria that I mentioned. And there was a here, but you can guess it from the angio, a major edge dissection that goes over 60 degrees, and that was going deeper than the intima. So we have to optimize, and we have to post-dilate with a non-compliant balloon the distal part of the stent, and we have to put a supplementary stent on the proximal LAD. That's what we did. And the result here is better. I think much better. So I would like just to finish by a special situation, the bifurcation on the left main. We already mentioned that during the discussion of the live case. I had the opportunity and the chance to publish the Lemon trial earlier this year. The Lemon trial was a feasibility and pilot study that aimed to demonstrate to prove that OCT guidance for left main PCI was possible in a standardized way, as you see here, which included 3 different OCT runs. The first OCT run was the pre-PCI, so I won't mention again the interest of the pre-PCI. The second OCT run was proposed in order to assess the wire position using some 3D OCT reconstruction, and I think that OCT is a better tool than IVUS for this for left main, because it can help you with that it can provide you some real-time 3D reconstruction of your artery and really help you to identify the stretch, the wire position. And so you know that in the left main, you have to, when you're doing a side dilation or a kissing balloon, the wire that goes into the side branch has to cross the stent into a cell connecting to the carina, and the only way to be 100% sure of that is to use 3D reconstruction. And there was a third OCT run in this protocol for assessing malposition, expansion, and dissection. So let me show you a case of left main. So this is a perfect candidate because the ostial left main is disease-free, and the lesion is really on the distal part of the left main and extends to the prox LAD. So the first run will help us to once again provide the metrics, and in this case the distal landing zone EL to EL diameter was 3.0, the prox was 4.2, and the length was 38.3. So perfect candidate for 3.0 per 38 Xience stent. The pot, so we decided to use a 4.0 pot, although the EL to EL diameter was 4.2. We rewired the side branch. You see that with the 3D reconstruction, you see here that the wire is going to the side branch into a cell connecting to the carina. So that's a perfect position to do the side branch or the kissing. But the second run also revealed that there was a malposition of the proximal part of the stent. Why? Because here you see that the stent diameter is always 3 millimeter. The diameter is always 3 millimeter, although the vessel diameter is much more than that. So it means that probably my pot was not enough proximal enough, and so I had to correct that. But if you're looking at the angio, it's not so easy to see that on the angio. Whatever, we will perform a kissing balloon inflation, and we're gonna go for a much better pot, much more proximal, and finish the procedure with our final OCT run, and the final OCT run demonstrated that their position was better, and there was no dissection. So that's a good result. The initial malposition was corrected. And so in this pilot study, we included a total of 70 patients. The procedural success was observed in 86% of the patient, and it was mostly due to inappropriate stent expansion according to the Lesion criteria. A correct wire position after the run number 2 was observed in 85% of the cases, and the wire repositioning by the operator was performed in 15% of the cases based on the OCT result. And Pci optimization was provided in 26% of the cases. So it means that although we dealt with some experienced operators, the guidance of OCT change the strategy is appropriate in almost 1 patient out of 4. In terms of MACE, the evolution, so the results were very promising during the first year of follow-up. This follow-up will be extended in the future, but you see that the survival free from MACE was 98.6%. So in conclusion, the OCT-guided PCI optimization is feasible in clinical practice. I hope I convinced you. And all the lesions except the ostral lesion could be treated this way. But in my opinion, so you can treat all the lesions. And I know, for example, Richard Schlofnitz in New York treats all he performs all these his PCI with OCT guidance. However, probably that the benefits are probably more marked in complex lesions. I think then the PCI criteria for the results assessment have to be applied, and they really simplified the approach, and the MLD Max algorithm also simplified the approach and the process, and it makes, I think, the things really easier. Don't forget to use all the OCT analysis software. The AptiView E5 is really great. The Ultrion is promising, and is, I think, quite supportive for the physician, especially if the physician has no real experience with OCT. However, so the benefits of the OCT guidance over the classical angio guidance, this benefit needs to be evaluated in dedicated trials, and that's going to be published in the next year, like October or Illumine 4. Thank you for your attention.
Thank you for your very nice talk and for your very good examples of the use of OCT. I will show you the final result of the case. This is the final angio. I think it's a very good result in a very severe and complex calcified lesion. And Santiago Jimenez Valero will show you the final result with OCT. And then I think we have time for 1 or 2 questions. Santi, please.
The right coronary, the distal part of the stent was nice, well expanded, well opposed, no distal dissection. In the middle part of the stent, there is a mild under expansion, which according to reference segments, 64% of expansion, but with a good point of minimal stent area of 5.3. And in the proximal part, I think that the expansion is very good. There's some tissue protrusion and residual dissections treated with the stent. And in the proximal part, it's still the minor dissections that we see previously that was not increased by post-dilatation.
Okay. Questions from the audience? There are some questions. Anna, Mateo,
yeah.
hello.
Yes, thank you for your brilliant presentation. You have said that you can choose the strategy depending on the extension of the calcium, of the degree of the extension. But do you think that the thickness of the calcium is also important? And will you change your mind, your strategy in cases of very thick calcium, such as the case of today, by using, for instance, coronary lithotripsy?
It's, well, it's supposed to, the deep calcification are supposed to be better targets for lithotripsy or orbital rather than rotational atherectomy. But, you know, these are, and I know some of my colleagues in France, they say that when you get deep calcification, there is no real option for rotational atherectomy, so they would change their mind. But I'm not sure that we have convincing data in the literature showing that. So that's why the future trials about calcium will be very important, because I think there are a lot of intuitions and things that we think are right, but we have to show that this different approach and this kind of this kind of plaque preparation tailored strategies in accordance to IC imaging will make a change for the patient.
Thank you.
We have a question from Dr. Rui Teles here in the chat. It's more about, he argues that the most important part of imaging is the optimization of the stent implantation. And he asks if there are any data from trials for the lesion preparation advantages of OCT imaging.
Oh, just to me, there is no real data, and I hope that our Calypso trial will provide some new insight. So I think that's why we designed this study, because there are a lot of proposals, but nothing is really supported by data so far.
No more questions. Okay, thank you so much, Nicolas. It was a great pleasure to have you with us and to help us with the live case. And then thank you so much. And see you in our fourth webinar on the 22nd of this month. Thank you so much.
Thank you very much. Bye bye. Thank you.